Good morning, students. Today we will see about some of the uterine prolapses. Before going to uterine prolapse, we will see what is retroversion. Retroversion is a term used when a long axis of the corpus and cervix are in line and all organ turns backwards in relation to the long axis of the birth canal. The first one is a picture of the normal uterus and second one is a picture of the retroverted uterus. Retroverted uterus, either congenital or acquired, is considered as a normal variant of uterine position. Retroversion either pre-existing or may be due to pregnancy. The incidence about 10% during the first trimester of pregnancy, where the angle between the long axis of the uterus and axis of the vagina is more than 180 degree. The uterus is said to be retroverted. In most cases, this causes no problem during pregnancy and corrects spontaneously as the uterus rises out of pelvic into abdomen as pregnancy progresses. The degrees are first degree, the fundus is vertical and pointing towards sacral promontory. Second degree, fundus lies in the sacral hollow but not below the internal os. Third degree, the fundus lies below the level of internal os. The causes first may be developmental due to the developmental defect. There is a lack of tone of the uterine position means muscles. The infantile position is retained. This often associated with short vagina with shallow anterior vaginal fornix. And acquired include piperial, that is structural ligaments cause the childbirth, fail to keep the uterus in its normal position. Prolapse when it happens in the prolapse, which is mechanically caused by the traction following cystocele. Tumors like fibroid, either anterior or posterior wall, produces heaviness of the uterus and hence it falls behind. And pelvic adhesions, either inflammatory, operative, or due to pelvic endometriosis, pull uterus posteriorly. The clinical presentation include mobile retroverted uterus that is common and almost remain asymptomatic. The symptoms include chronic premenstrual pelvic pain due to varicosities in broad ligament produced by the kinks, backache, dyspareunia, infertility. The signs include bimanual examination test reveals the cervix is directed upwards and forwards. Body of the uterus is felt through the posterior fornix. Speculum examination reveals the cervix comes in view much easily and external os point forwards. Rectal examination confirms the diagnosis. Fixed retroversion symptoms are related to associated with the pelvic pathology. Menstrual abnormalities like menorrhagia, congestive dysmenorrhea, chronic pelvic pain or dyspareunia. Prevention: to empty the bladder regularly, to increase the tone of pelvic muscle by regular exercise, encourage lying in prone position for half to 1 hour once or twice daily between 2 to 4 weeks. Corrective treatment include pessary. It is not practiced nowadays. For a pessary test, if the patient had symptoms of retroverted uterus like backache, chronic pain or dyspareunia, Hodges-Smith pessary placed for 3 months after correcting the uterine position to an anteversion. If the symptoms are absent during this period and recur back after its removal, it may be concluded the symptoms are due to anteverted uterus. In subinvolution of uterus in pregnancy, where spontaneous correction of anteversion fails by 12th week and rarely in case of unexplained infertility and recurrent early abortion. This is a picture of a pessary. Surgical treatment indicated in cases where the pessary test is positive, indicating that symptoms are due to retroversion, and fixed retroverted uterus producing symptoms like backache or dyspareunia. Genital prolapse. Genital prolapse is a descent of the pelvic organ secondary to the rupture of weakness of the pelvic floor support. It divided into 3 types: anterior, that means prolapse of the urethra and bladder or both into the vagina like cystocele and uretrocele. The pelvic organs are usually supported by ligaments and muscles, connective tissue and fascia, which are collectively known as pelvic floor. Weakening or damage of these support structures allow the pelvic organ to slip down. The condition is most common in postmenopausal women who have had children, but can also occur in younger women and women who have not children. It is estimated that at least half the women who had more than one child have some degree of genital prolapse. There are a number of different types of prolapse. The prolapse of a pelvic organ may occur independently or along with other pelvic organ prolapse. Prolapse are graded according to the severity, first, second, or third degree prolapse. Uterine prolapse. A uterine prolapse involves the descent of the uterus and cervix down the vaginal canal due to weak or damaged pelvic support structures. Cystocele. A cystocele occurs when the tissue supporting wall between bladder and vagina weaken, allowing a portion of bladder to descend and press into the wall of the vagina. Uretrocele. Uretrocele occurs when the urethra, that is a tube leading from the bladder outside the body, descends and presses into the wall of vagina. A uretrocele rarely occurs alone. Instead, usually accompanied by a cystocele. The term cystourethrocele is used to refer the prolapse of both parts of the bladder and urethra. Rectocele. A rectocele occurs when the tissue supporting a wall between vagina and rectum weaken, allowing rectum to descend and press into the wall of vagina. Androcele. Androcele is similar to rectocele, but instead of involving the pouch of Douglas, descending and pressing into the wall of the vagina. Vaginal wall prolapse. A vaginal wall prolapse occurs when the top of the vagina descends in a woman who have had a hysterectomy. Etiology. It may be because of predisposed like acquired or congenital, aggravating factors like postmenopausal atrophy, increased intra-abdominal pressure as in chronic cough and constipation, increased weight of the uterus as in case of fibroid uterus, undernutrition, traction by anterior wall or cervical polyp. These factors possibly operate where supports of the genital organs are already weakened. Acquired vaginal delivery with consequent injury to the supporting structure is the single most important reason. Injury caused by overstretching of macrotrods and urethrocecal ligaments by premature bearing down efforts, application of forceps or ventouse prior to the full dilatation of cervix, and downward pressure on the uterine fundus in an attempt to deliver placenta and precipitate labor. Overstretching of endopelvic facial sheath of vagina. Overstretching of the perineum in prolonged station of the head on the perineum, subinvolution of supporting structures, especially in malnourished women, early resumption of activities before tissues regain their tone, repeated of childbirth at frequent intervals, persistent overfilling of the bladder during puerperia. Congenital. Congenital weakness of the structure is responsible for nulliparous prolapse or prolapse following easy vaginal delivery. Clinical types include vaginal prolapse, that is anterior wall, that is cystocele or uretrocele. Posterior wall, it may be relaxed perineum, rectocele. Wall prolapse may be androcele, secondary wall prolapse, and uterine prolapse, like uterovaginal, congenital. Uterine prolapse occurs when pelvic floor muscles and ligaments stretch and weaken, no longer provide enough support for the uterus. As a result, the uterus slips down into the or protrudes out of the vagina. The uterine prolapse can occur in women of any age, but it often affects postmenopausal women who have had one or more vaginal deliveries. These are the two types. Uretrovaginal, that is the commonest. Cystocele occurs first, followed by traction effect on cervix causing retroversion of the uterus. Congenital, usually no cystocele, uterus herniates down along with the inverted upper vagina. Degrees of uterine prolapse. The first degree, uterine descends down from its normal position, but the external os still remains inside the vagina. Second degree, the external os protrudes outside the vaginal introitus, but uterine body still remains inside the vagina. Third degree, otherwise known as procedentia or complete prolapse, the uterine body descends to lie outside the introitus. Morbid changes in the vaginal mucosa. It is stretched and if it is exposed to air, become thickened and dry with surface of keratinisation. Decubitus ulcer found in the dependent part of the prolapse mass lying outside the introitus. Keratinisation leads to cracks, which leads to infection and slugging and ulceration. Cervix, vaginal part, chronic congestion which may lead to the vaginal part bulky and congested. Supravaginal part, it becomes elongated due to strain imposed by the pull of the cardinal ligaments to keep the cervix in position, whereas weight of the uterus make it fall through the vaginal axis. Urinary system. Bladder. Incomplete emptying of the bladder due to the sharp angulation of the area against the pubo-urethral ligament. Uretrus. There may be compressed by uterine arteries, so hydrouretic changes occurs. Incarceration. Infection of paravaginal and cervical tissues makes entire prolapse mass edematous and congested. Peritonitis and carcinoma. The symptoms include feeling of something coming down per vagina, especially while she is moving around. Backache or dragging pain in the pelvis. These symptoms will be relieved by lying down. Urinary symptoms include difficulty in passing urine, most strenuous effort. Incomplete evacuation may lead to frequent desire to pass urine. Urgency and frequency of maturation may also due to cystitis. Dysuria due to infection, stress incontinence, retention of urine rarely occurs. Bowel symptoms difficult to pass stool. Excessive white or blood-stained discharge per vagina associated with vaginitis or decubitus ulcer. Treatments. Preventive, that is conservative, and surgery. Preventive include effective antenatal care, that is nutrition supplement, antenatal hygiene, and physiotherapy with relaxation exercise. Adequate antenatal care, prevent premature bearing down effort, prevent premature application of forceps before cervix is fully dilated, avoid prolonged second stage, avoid too much fundal pushing and attempt to expel the baby, perform timely and adequate episiotomy, repair any perineal injuries immediately and accurately. Adequate postnatal care include prevent undue distension of bladder so as to facilitate involution of the pubocervical fascia, encourage early ambulation, encourage pelvic floor exercise, general measures like avoid strenuous activities for at least 6 months following delivery, avoid future pregnancy too soon. Conservative management. If subjective symptoms of something coming down per vagina with a slight cystocele or first degree uterine descent occurring within 6 months of delivery should be tackled by a palliative treatment. It includes assurance, improvement of nutritional status, pelvic floor exercise in an attempt to strengthen the muscles. Pessary treatment. It may be used in advantage in selected cases such as early pregnancy. Pessary should be placed inside up to 18 weeks when the uterus becomes sufficiently enlarged to sit the brim of the pelvis. Piparium to facilitate involution. Patients absolutely unfit for surgery, especially with a short life expectancy. Patients who are unwilling for surgery while waiting for surgery. It should be emphasized that pessary cannot cure prolapse but relieves the symptoms by stretching the hiatus urogenitalis, thus preventing vaginal and uterine descent. Surgery. Surgical correction is to place hiatal mass in position in treatment of prolapse. It is a corrective treatment unless there is sufficient reason to withhold it. Surgical correction is to be withheld in asymptomatic prolapse detected and accidentally. Young age with future reproductive potentialities is no bar for surgery in symptomatic cases. Thorough examination is needed to establish the correct diagnosis. There is no uniform procedure to correct all types of prolapse. Types of operations are anterior colporrhaphy designed to correct cystocele and uretrocele, colporrhaphy or perineorrhaphy designed to repair prolapse of posterior wall vagina, pelvic floor repair include anterior colporrhaphy and colporperineorrhaphy, vagina hysterectomy with pelvic floor repair, repair of wall prolapse, cervicopexy or sling operation indicated in congenital or nulliparous prolapse without cystocele where the cervix is pulled up mechanically through the abdominal route. Thank you for listening. If you have any doubts, please let me know.